My name is Dr. Tyler Tolbert,
And I'm Dr. Soren Poppy,
and you're listening to the Fix Podcast.
your source for all things implant dentistry.
Hello, and welcome to the Fix Podcast. Today we have Dr. Chris Barrett with us. We are super excited to have Chris here. I actually met Chris for the first time in Denver about 3 months ago, probably. And we've had a lot of conversations.
Sounds about right.
Yeah. We've had a lot of conversations since, and we've been sharing a lot of cases together. And we're very honored to have him on the podcast today. He is one of the front runners for Zygo implants, for GPs placing quad Zygos, doing remote anchorage cases. And we're super excited to have him on the podcast here today.
Yeah, excited to be here. Thanks for having me on. And yeah, we have had some great conversations ever since Denver. So yeah, what conference was that at?
I think it was the Dykema DSO conference.
Might have been that one.
Yeah, I came over to what was the big conference center that
hotel out by the airport that's massive.
Yeah, I can't remember either, but
Tip of the tongue.
yeah. Came out there,
Right.
we had a drink, we discussed both of our backgrounds, and we had a bunch of similarities in our backgrounds and getting into implant dentistry. And yeah, I'm sure the audience here would love to also hear about your background. So if you could fill us in a little bit, your background in full arch, maybe a little bit about the work history, how you got into remote anchorage. I think that would be a great start.
Yeah. I graduated from University of Iowa in 2011 and wasn't sure exactly what I wanted to do. Everyone that I talked to that had done a GPR was like, I would never trade another year of private practice for my GPR year. So I thought, okay, I'll take a year and do that. At the time, I really loved surgery and I really liked endo. And I think that was just because we had what I felt was just the best adjunct faculty in the oral surgery and endo department. So at least at Iowa, if you finished with your requirements early, you could spend as much time as you wanted to in whatever department. So I ended up spending a majority of mine in oral surgery. And we had these OS guys from all over the state that were at the later part of the years, and they just loved coming in and showing you all their little tips and tricks on exodontia.
Mm-hmm.
And they're just telling you all their little war stories and this and that. And I mean, it was just awesome. So I took to that and then did the GPR year. Honestly, watching the perio in dental school and OS faculty or guys or whatever place implants, I was like, man, that looks so boring. I mean, they'd take forever to place one implant, and it was based off of like a dental student guide that never fit.
Yeah.
And they're like, we're just going to do this ourselves. And I was like, this is what implants are? I was like, I'll just go do something else. I don't know. So I ended up practicing in Iowa for a year. And then all my siblings actually live in Denver, and my parents have siblings that are out there too. And looking to make a move, went out west from Iowa, and there's a lot of Iowa grads out in Denver. And so they'd been out there a number of years before me. I had gotten a job that all these guys were saying, hey, this is like one of the nicest offices. And so if you get selected for that job, you should take it. The caveat was that it was a restorative-only practice. So even though I was good at surgery and I liked different procedures, they're like, hey, we are a fee-for-service office. We work with other fee-for-service offices here in South Denver, and this is what you're going to do. And so I was like, okay, signed up for that. They taught 3 different levels of occlusion out of that office. And the guy who started that office, I'd say you and Tyler are younger than me, Soren, but let's say around the same age. And let's say some of the big names in whatever we're into have some sort of study club or go out and teach or whatever.
Mm-hmm.
And they're looking for guys to help teach. The guy who started that office, his mentor was a relatively famous prosthodontist named Niles Goucher. And he ended up inventing the Danar articulating system. He also developed something that was like a digital or a analog jaw tracer for that system. And so they were all about the study of gnathology and basically joint-based treatment, that as long as the joint was comfortable and the muscles were comfortable, you could restore someone and you could do it very predictably. And so they did a lot of TMD treatment, and they worked with a lot of really great orthodontists. And so most of that time was the cases that I was a part of was maybe phase 1 and phase 2. And then phase 2 is some ortho, maybe some minor restorative and a little bit of equilibration. Every once in a while, there'd be some surgery involved, but that was like a little residency that I didn't know that I needed. And I ended up restoring a bunch of implants and making good relationships there and some partial and full mouth reconstructions. That was the first first time I'd ever seen like an all-in-4 restore. And I just didn't know anything about it. And this is 2 or 3 years out of school. Looking back at it now, I'm like, oh, okay, I can see where there were some pitfalls or maybe some different things that maybe I would do differently. But that's where I learned how to restore it, the different analog restorative steps. They had labs that would come in. Well, the guy, Arnie Hoffman, and I don't know if you know him.
Yeah, I know Arnie.
So I met him when I was at that practice because he worked at one of the local labs. He's a German prosthodontist, kind of looks like Arnold Schwarzenegger, talks like him.
Yep.
Super good guy. So I cut my teeth on restoring those, doing it all analog. I ended up going through a divorce while I'm at that office, and I transitioned to a different office and start placing my own implants and getting back into doing some surgery. I ended up living with my younger sister, and I was like, hey, I got to get out of my younger sister and her husband's house, get out of there. And the local BioHorizon rep
Does Matt?
is Matt.
I was talking to him yesterday.
Yeah. He's woven into this story. His roommate had gotten his girlfriend pregnant, and so he had to move out. So Matt sent out a group text to like all the guys that were around the same age that would hang out every once in a while in the Denver area. He's like, hey, I got a room open if anybody's looking for it. That sounds good. So I ended up living with Matt for probably a year or so. And I'm listening to the AAID podcast, and Mike Frymouth is co-hosting with Danny Domain because Justin Moody was like out of town or something or whatever. And I hear that he's a diplomat and does a bunch about implants, and he's in Wheat Ridge, Colorado. And I'm like, wow, that's like right here. And I look up the ABY and diplomats, and there's like 2 in the state, and he's one of them. And I ask Matt, I'm like, hey, Matt, do you know this guy? He seems to know a lot about implant dentistry. He's like, yeah, he's like my biggest like client. Guy's like a month. He's just a machine. So I'm having dinner with him next week. So I'm like, is there any chance that I could go to that dinner with you guys? Do you think he would mind? I'll ask him, but I think it'd probably be good. So go over there, have dinner with him. He's actually looking for an associate. And at the time, I was planning on going back to Iowa to be closer to my kids that were back there. I don't end up working with him or for him, but I end up spending every single day off I can over at his office. And he really expanded my mind as far as what was possible as a general dentist. He was doing really nice FP1 cases in operatory 1 at the same time. Then he was prepping like a veneer case in operatory 2. And then he had 4 hygiene chairs. And then he had already built out his own in-house lab. I had 2 or 3 milling machines, 2 or 3 lab techs. And this is probably like 2013. And so when guys are like, oh, wow, I just built out a lab or whatever, I'm like, dude, you guys you think this is like a new thing that's just happening, but there's like these guys that were like a generation before you that were like,
it's crazy.
And they're done. And yeah, he's always tip of the spear, huge on education. That's why I started taking Kois stuff, because he was like, hey, you got to go take Kois. He did all the Mish and Kois stuff it was him and Moody way back in the day when he was our age. And those guys ended up starting Pathway. And through that relationship, I ended up practicing with Justin Moody for a couple years and taking over his implant practice. And then, so I went from placing a few implants a month to that's all I did. And fortunately, I had a really strong comprehensive dentistry and prosthodontic mindset. And I had previous good surgical skills from University of Iowa in the OS department there in the GPR that was just like very fundamental, basic things that I feel like you can use for forever in all walks of whatever surgery you're doing. So I'm super grateful for that. And then I ended up moving down to Arizona in 2019 and started a group called Brightly with some private equity guys and helped grow that to different offices around the country, which is basically just like guys that I knew or gals that I knew that, hey, that looks good. I want to do that too. And then left that in 2023, excuse me. And then I've just been traveling around the Phoenix Valley for the last year and a half or so, just doing all on X from basic all on force to advanced Zygo surgery. And then periodically flying around the country, mentoring or helping other docs, just trying to figure out what I'm going to do next.
Nice. Yeah. Yeah. It's funny. Matt Goff, so I've been working with him with BioHorizons. We use all of their biologics in our offices. And I think you made that connection actually so thank you for that, Chris. And yeah, and it was funny because I reached out to him yesterday just because I was looking for a sinus lift kit, and I just reached out to him. I was like, hey, do you guys sell these at all? I don't think they do, but I ended up going with a Selvin kit. So if you have any
Yeah. I
recommendations.
would have recommended Tatum, but that's fine.
Okay. All right. Yeah, I should have reached out to you first.
Now you tell
Yeah.
them.
It's all right. I'm sure the Selvin kits will do what I need it to.
Should be fine.
Yeah. And then he's like, hey, by the way, yesterday he said this, hey, by the way, Dr. Jen Mansky is my wife. And I was like, oh, no way. Because 2 weeks ago, I've got this patient who comes in and hey, doc, what exactly do I need here? And he had one of the most resorbed maxillas I've ever seen. Like, no bone. He had canine to canine bridge. And then from the canine to canine, there was absolutely nothing, like no bone whatsoever. And I was like, have you had this for a while? And he's like, yeah, when I was a kid, I got into a traumatic accident and lost my front teeth. And I was like, all right, well, all on four is going to be out of the question unless we like have some really extensive grafting, and that's not what you want to go through at this point. And I don't think he needed it either. But his lower bridge was definitely failing. And I was like, we can do a lower implant supported bridge. And I'm like, you should go back to your general dentist to see what they can do with that upper bridge, and maybe they can repair because it had fractured. And his dentist happened to be Jen Mansky. So I was on the phone with her like 2 weeks ago, just like we were talking about how we were going to like plan this case out. And then it just happened that they were married. And I was like, oh, wow. It's such a small world.
Freaking world.
Yeah. I feel like the dental world's small enough. And then once you get into the implant dentistry, it gets even smaller, which is pretty crazy.
Yeah. I went out to California about 2 months ago and did a case for a young woman, and she's telling me that her best friend practices in Arizona. And sure enough, there's only 3 or 4 offices that I really go to.
Mm-hmm.
And my girlfriend, who's a dental assistant, she does some temp assisting she literally has not done any sort of temp assisting for years. And then all of a sudden, like her second gig is this girl's best friend. I was like, okay, that's just too weird.
Right.
But yeah, that stuff happens all the time.
Yeah. It's funny you were saying earlier, separate topic, but you were saying earlier, I just wanted to mention this before I forgot, that when you first started like seeing implants, you're like, man, that looks super boring. Like, I'm not interested in that too much. And I remember when I was like second or third year of school, I saw these guys that were like implantologists, right? And they were like promoting themselves as implantologists. And I'm like, man, that just sounds so, I don't want to just do one thing, like just place single implants every day. That sounds like the worst thing ever. And
Yeah.
it's so funny, and it goes into what you were talking about earlier about milling and making your own lab. There's just so much that you don't know until you get into that avenue, right? So like you start to learn a little bit about implants, and then you're like, wait, what's this full arch thing? And all of a sudden you're like, oh my gosh, like it's so cool that all of a sudden you can have a patient that comes in who needed a denture that can have, a new set of teeth in a day. So then you get into the full arch stuff. And then once you're in the full arch stuff, the next kind of step is like maybe dabbling into remote anchorage. I feel like sometimes prior to remote anchorage, most people, and especially now, like in the last year or two, will start getting into like the digital dentistry stuff. And then that opens up a whole nother can of worms there. So you got all the remote anchorage stuff and then all of the dental stuff. And then you find out like for me, even if like setting up a mill in my office and stuff, I feel like I'm way ahead of the curve. But then in reality, there's people a decade ago that were like, oh yeah, I was doing that 10 years ago. And it's just amazing to see all of the different avenues and the things that you can get into, and how there's always someone out there that's like one step ahead of you, right? Doing these things.
Yeah.
And it's just interesting. I wonder what like the next big thing in dentistry is going to be. I think right now in like full arch, probably that would be like, I see guys now that they'll do digital designs and they'll have all the teeth designed already, but they won't place the implant positions. And then as soon as the implant positions are placed, they'll mill the first half of the zirconia. Then they'll mill like the access holes of the zirconia, is my understanding. And you can do same day zirconia deliveries. Have you seen that at all yet?
I haven't, but I'm trying to think of I'm not a huge fan of doing same day finals.
Mm-hmm.
I've done a couple of them, and if I were going to say, hey, I think that this was my mom or dad or whatever, I'd probably make them another one 4 months later.
Yeah.
So that's one of those things where but to be honest, but that's cool.
Yeah.
That's cool that the technology is like getting to the point of you can do that. So let's say it's almost like a healed ridge through a dentulous. You're like, I just got to drop some screws. And then you're like, oh, it can make you your final because I know if the soft tissue is, it's flapless or something. That's cool.
Yeah, no, definitely. And I'm definitely with you there. I tell all my patients that I prefer that they wait 2-3 months for all the bone to healing to occur, all the tissue healing before we go to your final prosthetic. But I do think for certain styles of practice, if people are traveling or something like that and they don't have a ton of time in your clinic, it can be a really good option for patients to get same day zirconia and then at the 4-month mark, then remill them in their with the changes that they've had to their bone and tissue. But I agree, as far as there's a lot of healing that occurs, and I don't think even 1 week finals and stuff are the best possible outcome for patients. But I think there's a lot of headway coming into that direction where some of these guys I've seen, they'll design the prosthetic in a way that they're planning it a certain distance from that bone level, right? So that way, when the tissue heals, they're planning for that. And maybe they end up having to remill 2 or 3 out of 10 arches. But at least those 7 arches that they did, the patients are still relatively happy with those cases.
Yeah, I think as there's more and more socket shield and root banking and remote anchorage, and I shouldn't say that in the same sentence. For example, I think for the FP1 cases that I've done, a lot of times you run into issues in the molars. Let's say there's just not a lot of bone there for a really solid molar. So you end up putting in a Zygo or a Terry, but you can do almost like root banking and socket shields in the front. When you have something like that's like a point of measurement when you're keeping something, then I do think it makes sense that you could potentially go closer to final versus, in my mind, an FP3 is a defensive modality versus let's say an FP1, which is more you're playing offense. And what I mean by that is you do your FP3, you do your surgery, and then you wait for everything to heal for 3 months. And then you're like, I'm going to wait to see how the body responds. And then I will now go back and I'll do the next part. Versus something like an FP1, you've got to play more offense and you have to do more connective tissue grafting. You might have to root bank. You might have to do something else to get the body to do what you want it to do versus, hey, let's just have this heal and then see what happens.
Yeah, no, I agree, definitely. What are your thoughts on, have you done a lot of socket shielding, root banking? I personally haven't done any of it. Our colleague Caleb, he has done a couple cases that have turned out pretty well, but I'm curious what your thoughts are on that.
Yeah, I've done 2 single socket shields. I've done some root banking, and the FP1 cases that I've done, it's been more a couple years ago, like xenograft and connective tissue grafting. I think if I were going to do them today, I'd change some of that stuff as far as root banking and some socket shields. I just saw an unbelievable lecture by a guy named David Attia, who's out of Australia.
Yeah,
and the amount of detail that it goes into as far as diagnosis and making sure you get a quality outcome with PET or socket shield or whatever, I think you have to select the cases right. The diagnosis has to be different. And it's not as, I would say, easy as straightforward as doing an FP3 where you're basically just giving yourself a blank canvas to create whatever you want. So yeah, it's very interesting. That's something that I'm excited to see how that develops as far as some more kind of innovation or techniques or things that just give really predictable results. Because I'll say from just doing a lot of FP3s, there's a couple patients that come to my mind where if I could redo that, I would do them as an FP1. And a lot of it was tongue space and phonetics and almost nothing to do with aesthetics, or these are older patients. It's not like it was a young patient that I'm like, hey, I just, artificially aged them by reducing a lot of their bone or something like that. This was just more, hey, we're our 8th try. And I know you're from New York and I know you speak Italian to your friends over in Italy and they can't understand that one word that you say. Yeah. Like they used to say with your natural teeth. I don't know what else to do, but if I could thin this out more, I think it would be better for you. And just the style of how everything was, I just couldn't make it any thinner. I learned my lesson just on a couple of those and I could see them coming now where it's, hey, whether or not the transition, these are low lips. I'm not going for unbelievably aesthetic FP1 cases. These are just thinner, smaller restorations where it's like, hey, the phonetics, I think, are a little bit easier. And I think there's a lot more tongue space.
Definitely. Yeah. No, I agree 100%.
Yeah, Chris, I think that's an interesting point because whenever I hear about indications for FP1, a lot of times it's what you just alluded to, a really young patient, a high lip line where reduction to hide the transition line is going to be pretty absurd for a given patient. And we're doing the FP1 to preserve that bony architecture, so on and so forth. But you're bringing up the phonetic point. So I'm curious, on the front end, prior to doing the case, so all those other things notwithstanding, how do you diagnose that phonetic issues that can
Yeah, the phonetic issues on those cases, the way that I would see them coming is they're more like wear cases. So they have very thin tongues will just annex territory as they are given more space. So these patients have worn out thin teeth. They may or may not have any sort of TMD or joint disease, which may or may not be symptomatic, but their tongues are big, their teeth are worn out, and they have, I'd say, a couple of the patients had accents already. And I will say that at least out here in the Phoenix Valley, patients that have had Eastern European or Russian accents or New York or Northeast accents have had a more difficult time getting back to like their natural cadence and what they sound like or their accent with a thicker prosthetic than I'd say Midwest patients or something like that. For whatever reason, I don't know if it's like when your tongue is sitting there and it's just laying naturally with your mouth closed, it wants to sit up against 8 and 9 right behind that area. And if you've placed your implants 7 and 10, and they're even in ideal positions, you still have this bump there. And that tongue wants to go, it's like interfering with where the tongue wants to lay. And a majority of the time people get used to it, but for whatever reason, so I don't know, those would be like the tip-offs for me. For these older patients, thicker accents, maybe not really philosophical patients where it's like, hey, I know that they're going to be very demanding. They don't even really want they're not aesthetically driven. They're just like, hey, my teeth are worn out and I need to do something. And I'm at the last part of this. Those are things where I'd be like, okay, I'm going to do maybe something a little bit different for you. They don't understand the difference between FP1 and FP3, even if you show them the model. It's like, you go into all of this stuff and it's too much detail. And it's like you spend 20 or 30 minutes with someone talking about what implants are and how they're going to work. And at the very end, they're like, so is that the same thing as a root canal?
Yeah.
And you're just like, okay, we got to start all over again. So you're trying to talk about nuanced stuff with phonetics, with different prosthetics, and it's good luck.
Yeah.
So that's where I think some of the experience just comes in, where it's like, I'm not going to charge you any different. I just know I'm going to try to avoid 8 try-ins with you, and we're going to do the case. I'm going to do it this way, and I'm going to do this other style. And so it's, hey, this is the best option for you. This is our normal cost, whatever. This is what I think.
For sure. Another thing that I think could be helpful, like after we see some longer term, some just length and studies about root banking and how it works over time, would be, I always see those cases too, where I see the teeth, and a lot of times it's a patient that probably is a grinder. They've worn down their initial teeth. The teeth they're in a position they can't be restored anymore, but they still have really good bone. And you can tell that bone is like super cortical, and it's just going to be a nightmare to get those teeth out. And in those patients, I feel like those are the ones that I get that you're taking out a canine or something and the buccal plate just comes. And there's nothing you can do. That tooth is like avulsed in there or ankylosed, and like it is just stuck in there. And at those patients, I know, hey, if I just keep that canine, I have such a better chance of getting these teeth out without causing any major issues with the bone. And those cases too, I think are really beneficial ones to do root banking on. And that's one of the main reasons that I've considered just like learning more about root banking and what it can do for these cases, because I think it could have a better, more predictable surgical outcome without having to worry about trying to get some canine out that is just going to be a nightmare. You know what I mean?
For sure. Can you imagine how much faster that surgery would go to if you just lopped that crown off versus
Yeah.
like back and forth and struggling and back. Yeah, it adds like an extra 10 minutes just to try to address the freaking canines.
Yes.
Yeah.
Yep. And then if you do break a buccal plate, then you're like, all right, now I need to find bone. We got to graft, get a membrane. Like it just adds so much time onto the case when it could have just been
Yeah.
avoided by just cutting the crown off. So I agree.
What's interesting is keeping those. So let's say, depending on like the arch form and your surgical plan, sometimes the tip of your implant is going, like for your posterior maxilla, is going right towards that canine.
Mhm.
So now you've got to figure out, hey, what's my posterior? Are you going to place pterygoids or not? There's just all these little nuances that as you get deeper into it, just like you were saying earlier, Storm, it's, God, would you just want to do single implants all day? Like, how easy is that? I mean, it's just a monkey could. But now we're talking about the nuanced difference between arch form and the tip of your posterior maxillary implant and angles and all that stuff, which I don't know, for whatever reason, it makes it interesting.
It does. Yeah. And there's cases out there too where people are putting their implants through teeth, right?
Yeah, Chris, I think you actually presented something like that at the SIN symposium a couple of years ago, where you put a pterygoid through a impacted third molar or something like that.
I think I had the first documented case, and
Nice.
Dan Holclaw put it in his book on, I can't remember which one it was as a case study, but guy was younger, didn't have the spread, I didn't want to do Zygos, and it's as soon as you learn how to do pterygoids, now all these patients have impacted maxillary ones, and you gotta be kidding. So yeah, so I did that. I did a 1-year follow-up on it and everything was fine.
Nice.
But yeah, it can be done.
Yeah.
Yeah, so now you can put that posterior implant through the canine and it's just more stability. It's great.
Exactly right. Yeah.
Yeah, I have a case actually next Wednesday, and the patient has just a massive canine from the floor of his mandible all the way up, and it's like taking out a huge chunk. And I'm like, he's older. I think he's 80 or something like that. And I'm like, I really don't want to take that out. It's going to cause so much more damage than like what it would help by keeping it. So I think in this particular case, I'm pretty sure I can work around it. I think I'm going to use like a 10 millimeter implant, and I should be able to go right above it. And then my other implant will be on the other side. My problem is I'm super OCD about symmetry, and I love symmetry. So in my head, I'm like, like it's going to drive me nuts not taking that canine out.
We have symmetry points on that for sure.
Yeah, definitely. And
You know what's asymmetrical is when you break a jaw.
yes, exactly. So that's what, like, in my head, I'm like, all right, like I would love to take this canine out, put the implants in a perfect position so I have that nice, pretty pano after the fact. However, this one is not the one. So we're either going to have to work around it, or I just have to use that canine for extra stability with my implant.
Before I did that case, I went through and I tried to find other documented cases of implants in teeth, and a majority of them are impacted canines.
Mm-hmm.
A majority of them are in the maxilla. And there was maybe like 10 or 15 really good documented cases over a period of at least 5 years. They all tried to avoid going into where the nerve, like where the vascular canal of the tooth or the nerve was. So I also tried the implant that I put through that pterygoid, the positioning of the tooth, I was able to avoid it because I cut a hole through part of the root, but a majority of the crown. So I didn't know if there was any sort of nerve bundle going into the tooth.
Mm-hmm.
So depending on what your case looks like, now if you just go in, the cases that are documented, they were just going into the cementum of the side of the root. They weren't like blasting through the middle of the root.
Yeah.
I don't know if that's helpful in your case or not. 80 years old, they've got a lot of tertiary dentin going on in there, may or may not.
Yeah, I think I'm probably just gonna work around it in this situation. But it's fun to think about, right? Because I'm sure there's gonna be another case that comes up in the near future where it's a similar situation. And it's good to know that you have that in your tool belt if it comes to it. But so let's talk a little bit about, I think a lot of our listeners want to hear about your experience with remote anchorage, because whenever I think of go on your Instagram and stuff, we see a lot of these remote anchorage cases. And I think people would love to hear what your recommendations are for not, maybe a good start would be like, let's say that we have someone who maybe is placing a decent amount of implants. They want to get into full arch. What are your recommendations for first getting into full arch? Like how many reps should you have? What do you recommend there? And then after you get into full arch, what are your recommendations for like getting into pterygoid implants and then getting into Zygo implants? And what courses do you specifically recommend for people who are looking into getting into that style of dentistry?
my remote anchorage journey was when I started doing full arch up in my very first one, like restoratively, it was in Colorado. And then I did one surgically while I was there, which if I look back at now, God, what the hell was I thinking? And then a majority of them when I got started was up in South Dakota. And I had tried all sorts of different techniques. I'd done freehand. I did probably every stackable guide system. There was, because I was like, oh, maybe this is the answer, or there's, at the time, just not knowing what you just don't know what you don't know. And there's so much marketing behind full arch. And as a young practitioner trying to figure out what exactly you should be doing, you get sold some stuff that once you figure out, maybe this isn't the best way to go about it. So I felt like I was relatively well-versed in what was out there for full arch. And then I remember I had a case that my posterior maxillary implant, it failed, came back, grafted it, failed again, came back. Luckily worked that third time, but it took the treatment plan from 6 months to 18 months. I'm like, man, I didn't know anything about remote anchorage at the time. I'd moved down to Arizona, and there's quite a bit more competition down here. And so there's probably 3 or 4 guys on my street that offer teeth in a day type of services. And I could not tell patients, if I don't get adequate stability with your implants, unfortunately, you're going to have to heal with a denture for 4 months. That just wasn't going to fly. So it forces you into, okay, what are the other things? My first course was out at Ramsey Amin. He'd offered like this private cadaver course on zygomatic and pterygoid implants. Thought that was interesting. But I wasn't really sure what I was going to do with it, but it started to give me some vocabulary that my mind could use a little bit or kind of follow along with what other people were doing. And then went down and did Dan Holtz-Claw's, I think, very first course, which was in Dallas. You had guys like Mike Picos there. It was like cutting edge stuff. He's learning at the same time I'm learning. I was like, oh, that's cool. And then ended up doing a couple live surgery courses, one down in Brazil with Smiler and Rosen, and then did Vichy Bruman's course here in Scottsdale. In between the cadaver course and live surgery courses, I would line up patients to do in my office.
That's smart.
And so it wasn't ever, okay, spend a bunch of money and take this time out, and then 6 months later haven't used anything. So that's how I got into it. And at the time I was doing enough arches where I could find arches to practice on or do these things that I felt like needed them. And I think one of the biggest things, or the reasons why to get into it, is if you're doing full arch, the ability to revise your own cases, which I think is a really big deal. One, from just a practitioner standpoint of wanting to be able to provide that. And 2, from the patient standpoint, to quickly and efficiently move them from point A to point B without this huge either stop in their treatment or detour where we're not exactly sure what's going on. I can't fix this. I know I told you I'm the guy that you should trust with your treatment, and now you got to go see someone else, something along those lines. Yeah. The ability to move cases along and revise your own cases and treat more cases, I think, is a really big deal. The other thing is, I was told, or I will say that there is like some philosophy out there that you should be doing 100 all-in-4 arches before you even get into remote anchorage. Those same guys are like, well, every case should have pterygoids. Yeah. Okay, do you want me to do 100 cases without pterygoids first and then do pterygoids and then have those patients back because you're telling me every case should have? It didn't make a lot of sense. And I was like, okay, that's interesting. I think the rationale is, hey, get comfortable doing surgery and get comfortable with these flaps and get comfortable with the process before getting even further into other sensitive techniques or difficult techniques. And that's 100% understandable. One of the issues is previously teaching courses or helping teach courses on some of this stuff is that if you teach someone an all-in-4, you've given them a hammer, and when they get back to their office, like all of the arches look like all-in-4 arches. And what happens is, sure enough, you get a call or hey, I did the reduction like I was supposed to. I put my implants in and I don't have like enough AP spread. And the reason why they get into that is that they have not gone through other remote anchorage or treatment planning courses where it's like, hey, that case just wasn't treatment planned correctly because you also need all of these other tools. And I don't know, I would suggest that people get into remote anchorage training early if they want to do all in foreign arches, specifically to learn the value of the treatment plans so that you can stay out of basically the deep end for cases that you don't need to all of a sudden find yourself in.
Yeah.
I think one of the biggest advantages of me learning a lot of pros stuff and joint stuff was not that I wanted to treat all of those cases, but it was to avoid the cases that were going to be a huge headache for me and my team and the patients. I would say go to the live surgery courses, go to the cadaver courses, sprinkle in some patients, whether or not you're going to start doing those cases right away. But once you have that knowledge, you can't unsee it.
Mm-hmm.
And when you start looking through your CBCTs, you're going to be like, this is probably a Terry Zygo patient. I shouldn't try to sneak in an all-on-4 on this one, something like that. The other thing I would say is take some sinus courses because you need to get comfortable being in the sinus if you're going to be doing Terry's and Zygos. I'm not saying you need to do additional grafting with these, but if the first time you're getting into the sinus is that you're cutting a slot for your Zygo, you're not going to have the same feeling of, hey, I've been here before. I'm not worried about this. I'm worried about the orbit, as if you've done a bunch of sinus work and you're like, hey, this is no big deal. If there's an issue, I can repair it. This is not a factor. I'm focusing on what I should be focusing on, which is the treatment that I'm trying to provide.
Yeah, definitely. I agree 100%, especially with the learning, like what remote anchorage can do for you and what remote anchorage can do as far as treatment planning goes. There's so many doctors out there who are so excited to get into full arch. They go to their first course, maybe they get 4 or 5 arches under their belt, and they're just looking for that next patient to do a case on. And that maybe that next patient happens to be someone who just has like super pneumatized sinuses, and they're like you said, trying to sneak an all-on-4 on a patient that's going to have canine access holes. And then you're stuck in the situation where the only option you have is you either do one molar, or you just have this really big cantilever, and the patient just isn't in the best prosthetic that they could be, or you're just going to be dealing with this patient for the next year. And like those 15 appointments that you have where a patient's just frustrated with you, they're frustrated that they decided to do the treatment at this clinic. It's not worth that 20 grand or whatever you got for the patient's initial surgery. So being able to
without a doubt.
Yeah. Being able to avoid those patients and avoid those problems for you and your team is going to allow you to do these cases for a much longer period of time. Tyler and I have trained a lot of these doctors for quite a while and saw their progression up. And there's so many doctors that get into this and then they quickly realize, because of problems that they've had with these cases, wow, I do not want to do this anymore. Like I thought this was what I wanted to do. Maybe they had 2 or 3 cases that just didn't go the right way and they had patients really frustrated with them. And then they just decide, okay, this is not the style of dentistry for me. And in reality, if they would have been able to see those cases up front and avoided them, they probably would have been able to do so many more arches, got so much more experience. And that way, when one of these problems came up, they're like, okay, let's handle this. We can do this. And it would have just elongated their career in this style of dentistry.
100%. I think almost every course that either I'm helping with or that I've attended, someone will say, hey, what's the next course? What should I be doing next?
Mm-hmm. And
I would say it's not necessary. There's no one single course that you're going to learn all this stuff. You've got to take them all. And you're going to learn, depending on what like evolution you're at in your career, you'll learn different things from those same courses. I think the biggest thing is just finding a mentor. And so those mentors will help you treatment plan those cases that you're not sure of, because you're 100% right. If you get burned by your first 2 or 3 cases, I mean, you've just been scarred and you're not going to do this.
Yeah, I agree. Absolutely. I want to get into as well. And funny thing I wanted to mention too, you were mentioning that Mike Picos was at the course you were at. When we went to, Tyler wasn't with me this time, but I was in Portugal for a palatal approach course with Bernardo, and Mike Picos came to that one. So it was really cool. I have this picture of Bernardo and Picos both like on both sides of me while I'm like in there doing like a case. And I was like, oh, this is it was just like a
It's-
cool moment for me.
More specifically, Picos is assisting you while doing the case. I hate that photo so much.
Yeah, I loved it. I was like, oh, this is
Yeah.
He's holding suction for you while you do a sub.
That's awesome.
yeah. But it was just cool to be there because
Hmm.
it was reassurance that I was like on the right path of kind of the forefront of new techniques, right? Because I'm like, okay,
Yeah.
Picos is here. Obviously, I'm in the right course for sure because he's trying to learn this as well. And it was also cool because he did a whole over in Europe right now. I think subs are like a big thing, like the new sub, right? So he went
Custom implant.
yeah, the custom implants. And he went over all of these like mandibular sub cases that he has done over the last 50 years. And he showed like follow-ups, maybe not 50. I don't know exactly how long he's been practicing, but he's showed follow-ups over 30 years time of all these mandibular sub cases that have worked really well for him. And was just reassuring the group of these custom implants, they work. You just if you plan the case correctly, you do your flap correctly, they can be another powerful tool for patients in this journey. Because I feel like a lot of patients, they're in this kind of this cycle where the first thing is a full like a traditional all-in-4. And then if anything happens with that, then what's the next step? You either have to decide. Right now, the biggest thing is Zygos, right? But if there could be a solution in between those two, where it's maybe we do a custom implant, and then if that custom implant doesn't work, then we can get into like quad Zygo territory. I don't think we've mentioned on this podcast, but I know that you've mentioned it to me previously, where like the number one thing to avoid, as long as you can, are quad Zygos, right?
That's what my mentors have told me. So I just try to do what they tell me.
Yeah, you reiterate. So it'd be cool if there was predictable option that we could go to prior to going to that quad. And I don't know for sure if the custom implant is that option. It sounds like it is. I have seen a couple of the cases being done, and there is a decent amount of reduction still and a decent amount of slots. But I think that it's going to be a powerful thing in the next 10 years in implant dentistry. It's not approved, obviously, in the US yet. But what are your thoughts on that?
Yeah, my thoughts are there's a gentleman named Sam Jurek over in Tennessee, and he's seen a lot more dentistry than I have. And he's okay, we've already been here and we've seen a lot of maxillary subs fail.
Okay.
Mandibular subs are something different.
Mm-hmm.
And I think I've met Bernardo a couple times and I've had nothing but positive interactions with him. And I think he's a great educator. He speaks well. He carries himself well. I don't agree with everything that he says though. I had a case yesterday in an office where first I did a palatal approach, didn't get the prosthetic like timing where I wanted it. I thought it was going to be too palatal. I thought it might infringe on the tongue space. Then I tried a tree and sinus and couldn't get the torque that I needed, as well as the arch form with the two anterior implants even angled so I could get my posterior one to slide in. It just wasn't going to be as ideal as what I thought the patient needed.
Mm-hmm.
So I transitioned and put a Zygo in.
Mm-hmm.
And is that a case for a unilateral custom implant sub on that side? I don't know, but that doesn't make a lot of sense to me. I think the other thing too is, I don't know how much they cost over in Europe, but over here, they're very expensive.
Very, yes.
And so imagine if you're like, zygomatic implants are $5,000 a piece.
Yeah.
It'd just be like, that doesn't make a lot of sense.
And
It's just I understand a little bit of the rationale. Now, here is my take on why and I haven't had this conversation with Bernardo, but this is my take on it. He was at the Malo Clinic for a number of years, and that's where he got a lot of his training. He saw a lot of arches, a lot of patients. My understanding is that they used Nobel zygomatic implants. Nobel's, and I don't know the exact approach that those clinics were using, if they're using the original Brandemark approach, if they're doing a Stello and Warner slot technique, if they were doing extra maxillary approach, if they were doing some Zygo concept or a combination of all of those. I'm not sure. But the way that Nobel zygomatic implants are, you are going to have a higher rate of complication, 100%, from the design and the technique and their instrumentation and how you place them versus some of the newer techniques and instrumentation and implants on the market.
mm-hmm.
I'm curious, when we talk about newer, obviously we're talking slot techniques, extramaxillary techniques. I think a lot of the Zygos that Bernardo would have seen, and I don't want to speak for him, but during that time when he was at the Mayo Clinic, were probably intrasinus. And I think you're right about the Nobel zygomatic implant. What were some of the features of the implant itself and also the technique that may have led to some negative bias towards that?
So the original one that Brandon Mark had fabricated, which was at the same time fabricated with the other implants. So it's been around just as long. It's not like a newer thing. Those implants were originally made for cancer resection and trauma patients. If I were to show you some so there's a book called the Osseointegration book. I might have, it's right here.
You put up on the screen for our YouTube guys.
This is one of my favorite books.
Okay.
And it documents.
That logo is very interesting, actually.
Yeah, this logo is like severe atrophy, restorative implants.
Have you seen the Fix podcast logo?
Fix one? Yeah,
it's ours.
Yeah.
It's missing pterygoids.
Yep.
That's ours isn't.
But it's one of those things. If I were to show you some of the original cases, what he does is he goes through and he says, this is patient number 1, and he follows them. So this is like,
wow.
Case number 1, jaw number 1 by Brandon Mark. And then he shows his follow-up. And this is what he does. And here's the original. And guess what? The posterior implant fails. And guess what he does? He puts in a zygomatic implant. Like some of these panels look like today's remote anchorage panels. It's pretty wild.
Person out of time. Person out of time. It's crazy.
The original implants were machined. And they're basically just like long bolts. And it's mainly an intrasinus technique. They didn't have angled multi-units at the time. So some of those original occlusal shots where it's like, God, why would someone have the implant coming right like out mid-palate or whatever? It was a 0-degree abutment. There was no like, hey, swing it over 60 degrees. So some of that was just what they had. And then the other part of it was they didn't have great torque with some of that stuff, as well as the end of the implant had a little nipple on it. And so they would have this technique where it's intrasinus, and then they would feel the drill come out, and then they would feel the edge of the implant to make sure that they knew that it was in far enough. So you potentially had pressure underneath the tissue that could cause some sort of fistula or something like that.
Yeah.
So at the time, if you want to get better integration, because we've had some failures with these, let's coat the surface with something. And now let's stick it in the sinus, which the surface coating might make sense for integration, but as far as sinusitis and issues with the sinus wasn't probably the right thing to do.
Yeah.
So I think if you combine those things and you do a high volume of those and you look at some of that stuff, you're like, hey, I think there's a better option. And maybe a custom implant would be a better option because you can avoid all these things. But I do think that over time with extramaxillary technique and pterygoid fixation behind it to give those implants stabilization, I think you can eliminate a lot of those problems.